Hello, my name is Jolie Puckett. I'm a student at Jacksonville State University, and this is my project on decreasing diabetes done through NU712 Clinical Prevention and Population Health with Dr. Arlinda Wormley. My project will cover diabetes, the population involved, my area of interest, the 3 levels of health prevention, the program itself called Decreasing Diabetes, the teammates involved, the specific DNP role, the education needed, resources provided, and how we will evaluate. What is diabetes mellitus 2? The chronic condition known more commonly just as diabetes. This is a set of metabolic disorders or syndromes recognized as chronic hyperglycemia occurring due to imperfections in insulin action, insulin secretion, or both. About 1 in 10 adults, or over 30 million Americans, currently live with diabetes. 1.5 million Americans are diagnosed with diabetes every year. Left unmanaged, the condition can lead to a variety of serious and costly complications, including renal failure, amputations, and blindness. Type 2 diabetes is the most prevalent type, and it accounts for approximately 90% of all diabetes occurrences worldwide. Globally, type 2 diabetes imposes a large economic burden. Diabetes is estimated to affect 366 million people globally by 2030, and possibly increase to 693 million people by 2045. Diabetes was the 7th leading cause of death in the United States in 2017 based on the 83,564 death certificates in which diabetes was listed as the underlying cause of death. Diabetes may be underreported as cause of death. Studies have found that only about 35 to 40% of people with diabetes who died had diabetes listed anywhere on the death certificate, and about 10 to 15% had it listed as the underlying cause of death. Diabetes mellitus is a chronic condition with a growing prevalence and high economic burden in the United States. Average medical expenditure among people with diagnosed diabetes were 2 to 3 times higher than what expenditures would be in the absence of diabetes. What are some of the symptoms of diabetes? Frequent urination, being very thirsty or hungry, feeling fatigue or malaise, changes in vision, cuts or bruises that don't heal easily, weight loss or weight gain, tingling pain or numbness in the hands or feet. Many symptoms can go unnoticed or may be disguised into other health problems. Urination could be a UTI. Another example is thirst could just be dehydration. Fatigue could be from depression, a thyroid issue, or viral disease. Cuts and bruises will be slow to heal or may not heal at all. Neuropathy is common, starting in the legs. It may be diagnosed as restless leg syndrome. Early detection and treatment of diabetes can decrease the risk of developing further complications of the disease. Diabetes is a long-term illness that can cause disease-related complications if not controlled in the earliest state. Some of the comorbidities that are commonly associated with diabetes mellitus is kidney or renal disease, coronary artery disease, obesity, hyperlipidemia, vision changes, neuropathy, poor wound healing, or low libido. Diabetes management itself is a lifelong process. Most patients must make complete lifestyle changes. Effective disease control involves more than just a regular doctor's office visit. It includes a variety of patient-driven factors ranging from diet control to be able to recognize symptoms of hyper or hypoglycemic episodes. Not all patients with diabetes, however, have the access to resources needed for successful disease management. Quality clinical care and self-management are compatible and dependent on each other, and without sound care, a patient's efforts may be misdirected. An expert clinical care will fall short of its potential through patient failure to use prescribed medications to control his or her blood sugar or to implement its management plans. While this repetitive task seems to be a mundane part of diabetes, it allows the patient to self-monitor how they will be doing with medications and diet and determine if further adjustments are needed by the primary care provider. Along with blood sugar, it is encouraged to have a regular monitoring of blood pressure, BMI, cholesterol, kidney, eye function, and encourages regular foot exams and all self-monitoring aspects of diabetes. I wanted to focus on the area in which I live, which is Northwest Georgia. Diabetes affects many people, and it seems to focus more on low-income communities and minorities. Health disparities often lead to higher frequency of diabetes in poor and minority groups. Studies found compared to whites, blacks, Hispanics, and American Indians, they all have higher rates of being uninsured in the United States. Low-income populations also have a higher rate of being uninsured versus those with more income. Consequently, these low-income and minority populations have limited access to care and poor quality of care. More African Americans, Hispanics, and Asians consider the emergency room as their main source of health care compared to whites, and thus were less likely than whites to visit a primary care provider or private practice. Health insurance status may factor into proper diagnosis of prediabetes and diabetes. Health insurance was associated with decreased odds for undiagnosed prediabetes and type 2 diabetes in American adults. Findings highlighted a large proportion of individuals without health insurance have undiagnosed prediabetes or type 2 diabetes, and are therefore probably not managing their blood glucose levels properly. Some of the risk factors involved may be genetic, metabolic, or environmental. What are the levels of health prevention? Curley explains the 3 levels of health prevention in the text provided to us. Primary prevention refers to the process of altering susceptibility or reducing exposure to susceptible individuals and includes general health promotion and specific measures designed to prevent disease prior to the person getting the disease. Interventions are designed for primary prevention are carried out during the stage of susceptibility. The earliest detection and prompt treatment of disease and the earliest possible stage are referred to as secondary prevention. The goals of secondary prevention are to either identify and cure a disease at a very early stage or slow its progression to prevent complications and limit disability. Secondary prevention measures are carried out during the preclinical or pre-symptomatic stage of the disease. Tertiary prevention is the 3rd level. Strategies are implemented during the middle or late stages of the clinical disease and refer to measures taken to alleviate disability and restore effective functioning. Attempts are made to slow the progression or cure the disease in cases in which permanent changes have taken place. Interventions are planned and designed to help people lead a productive and satisfying life by maximizing the use of remaining capabilities. The primary prevention is here. It is the first. You want to catch it before it gets to the secondary. The secondary is the most common health prevention. This is when people are first being diagnosed, and then the tertiary is the 3rd and last, often when the disease has progressed. The Decreasing Diabetes Program is a secondary health prevention. I chose to go with the place where I'm employed, which is Atrium Health Floyd Hospital in Rome, Georgia. My clinical expertise is within the hospital system. The secondary health prevention program is to increase knowledge for diabetics, and improve clinical outcomes as needed. This program aims to increase diabetes knowledge for patients admitted with a diagnosis of diabetes mellitus 2, regardless of this is being new onset or if it's a chronic diagnosed condition. Some of my goals will be to decrease the A1C overall, medicine compliance with the patients and their families, accurate recording of the blood glucose level, skin inspection and wound care, increase their knowledge of the disease, and a decreased rehospitalization rates related to diabetes complications. There are some similar programs out there, however, none within the hospital setting that I could locate easily. Some of the programs I did find had some great information. The evidence-based lifestyle programs targeted at improving diet, exercise, and weight loss can effectively delay or prevent type 2 diabetes, which is ultimately the goal. A study among American adults who were told that they have prediabetes and are at risk for developing type 2 diabetes. The results was that 68% attempted weight loss management, 55% had increased physical activity or exercise, 60% reduced dietary fat or caloric intake, and 42% engaged in all 3 activities. Who will make up my team? The program will be led by the DNP prepared nurse. Each member of the team will serve as an instrumental part of this program. The primary RN will provide in-person education to the patient and the family members. The CNA will be responsible for taking the patient's blood sugar, providing them with appropriate snacks as needed. The diabetes educators will provide an in-depth education on diabetes, obtaining a blood sugar, meals, snacks, medicine, and healthy living. Dietary will provide the patients with an appropriate diabetic diet. Exercise specialists will work with the patients in the hospital on how to do simple exercises at home. This is my graph for my interdisciplinary team. This is the team, and these are the components that make up the team. What is the role of the DNP prepared nurse? The DNP prepared nurse has a background that will be essential in this project. The DNP will need to be a strong leader to provide guidance throughout the program. The DNP will coordinate the program and all its components, including building the team, needs of the program, budgeting, and all business aspects. A skilled planner is a term coined to describe the leader of the project. The skilled planner must be prepared to answer questions about the program before, during, and after as the questions arise. The DNP will need to be a nurse that is experienced within the hospital and it specializes in diabetic patients. The DNP is educated in population health and on management, doctorate level education with classes on both. The American Nurses Association listed many leadership competencies that are required for a DNP nurse to lead these projects. The largest one to me was the communication. Communication effectively includes disseminating information about decisions, plans, and activities. You want to express ideas clearly, prevent unpleasant surprises, and encourage and direct open discussions. They need to be organized, write clearly and concisely, and convey idea through examples and images. They are the project manager. They will organize, set tasks, set priorities, able to help the employees do the same. The prioritizes projects and tasks logically, is good at helping employees, and is a good coordinator of all. Finally, I chose vision and strategy. The DNP needs to have a vision for the project. The strategic planning develops long-term objectives and strategies and translates this vision into a realistic business strategy. They weigh the concerns of all relevant business function when developing the plan and discusses all organizational needs. What education will be provided for the patients? One of the more crucial elements of self-monitoring is the responsibility of the patient to check their own blood sugar. While not every type 2 diabetic patient has been educated to monitor their blood sugar at identical intervals, glucose monitoring is an important component to disease progression and an integral evaluation of diabetic control. Patients are encouraged to write their blood sugars down into a notebook with timestamps. They may also use an application on a smartphone to track their glucose levels. It was revealed after a study that adults with an increased risk for diabetes significantly improved lifestyle factors associated with weight control, physical activity, and caloric intake. The adoption of these healthy behaviors was significantly greater in individuals who were made aware of their increased type 2 diabetes risk compared to those who were unaware, such as those who are uninsured and do not have access to health care. Their education component will be that of healthy eating. The first component of self-management behaviors is healthy eating. Because of the chronic nature of diabetes and skills for long-term discipline, it will be beneficial for the population to have knowledge and appropriate food choices. The importance of a balanced diet that is attentive to complex carbs, fruits, vegetables, lean protein, and education on meal planning, portion control, and carb counting. Exercise is another component for education. Physical activity should be incorporated as a daily routine of the patient who is involved in the Decreasing Diabetes program. Physical activity provides a means for weight loss, stress reduction, blood sugar stabilization, and improvements in cholesterol. Starting out slowly and adapting to small time periods of exercise will yield greater results in exercise adherence. Yoga, outdoor walks, stretching, and basic body mechanic movements are a great way to start exercising without feeling overwhelmed. Many exercises do not require a gym. These exercises can include warm-up, cardio and aerobic, strength training, balance, stretching, and cool-down exercises. How frequently should they do it? 30 minutes or more a day is what's recommended, at least 3 times a week. Medication compliance and adherence is a large issue within the diabetic community. It is a necessity to take diabetic medications as prescribed. Commitment to medical adherence in diabetes care is linked with lower morbidity, mortality, and treatment costs. Some oral medications include metformin, glipizide, arquebus, sitagliptin. Some patients are also on insulin, either short-acting, long-acting, or both. These medications are Lispro, Aspart, Glargine, Detamir, and Isophane. Education on medication is one of the most important aspects of diabetes teaching. Patients will need to know the name, why they are taking it, the dose, timing, side effects, and medication interactions. Unfortunately, diabetes also often comes with other comorbidities such as hypertension, hyperlipidemia, cardiovascular disease, and kidney disease. The importance of taking blood pressure medications, especially ones with kidney protection such as ACE inhibitors, medications to lower cholesterol levels, and aspirin to reduce the risk of heart attack is a factor to be included. Uncontrolled diabetes can lead to worsening of these other comorbidities. Blood sugar testing provides useful information for diabetes management. It can help monitor the effects of diabetes medications on blood sugar levels. It can identify blood sugar levels that are high or low. It will track the progress in reaching the patient's overall treatment goals to keep a running tab. Learn how diet and exercise affects blood sugars and understand how other factors such as illness or stress affect blood sugar levels. Trends will occur when a patient is fasting, sick, eating, sleeping, or prior to mealtime. The target range is 80 to 130 milligrams per deciliter. A large portion of our diabetic patients are admitted to the hospital with skin and wound complications. The primary function of skin is to serve as a protective barrier against the external environment. The skin provides a protective barrier to the outside world and the threat of damage, but that function deteriorates as the skin ages, making older people more prone to infections, pressure ulcers, and skin failure. This is compounded by any comorbidities, particularly diabetes, which can increase skin dehydration and encourage fungal infections and pressure damage. The greater frequency of infections in people with diabetes is caused by the hyperglycemic environment that favors the immune dysfunction. People with diabetes are also vulnerable to fungal infection. Candida albicans is a yeast-like fungus that is responsible for many fungal infections, causing skin problems in people with diabetes. The incidence of fungal candida in diabetes has risen sharply in recent years, and this may be due to excessive glucose levels, as glucose is an excellent source of fuel that can rapidly increase the growth of candida. What are the risk factors and how do we reduce them? Unfortunately, not all risk factors are modifiable or can be changed. Those such as your family genetics, being a minority, or being 45 years of age or older are not changeable. Risk factors such as prediabetes, being overweight, waist-to-hip ratio, and not enough physical activity are all factors that can be modified. The goal of this program is to talk about the modifiable risk factors, educate the patient, and decrease their risks. Diabetes educators are nurses in a separate department in the hospital. They provide education to inpatients with diabetes. Diabetes Education Consult will be triggered when a patient's A1C is greater than 7%. Education can be given in personalized or group settings by certified diabetes educators or healthcare providers. The nursing assistant will check the patient's glucose level at least 4 times a day. This is a learning opportunity for the patient to practice sticking themselves to acquire the blood sample. Each time the nurse gives the patient insulin, it is a great time for teaching, and the nurse can allow the patient to practice self-injections of insulin. In my experience, patients often have a better understanding of what to do after they are allowed to be hands-on in their care. If a patient is a new onset diabetic, they will often be prescribed oral medication or insulin. Extensive education will be provided to the patient prior to discharge. The utilization of smartphones. Apps are a low-cost, accessible resource to patients. Health disparities can cause a higher rate of diabetes development in poor and minority groups and also limit the care these people receive. Providing health resources via mobile devices like smartphones may help address the health disparities. Unlike traditional means of health care, the smartphone is an accessible resource and readily used by minority and low-income populations. Over 95% of American adults own a cell phone. Of these, 77% own a smartphone. A current search revealed over 1,000 commercial applications related to diabetes available in the U.S. Apple iTunes Store and Google Android Play stores. I was part of making a video for Atrium Health Floyd. It is a YouTube video on how to check your blood sugar and another one on how to administer insulin. These are screenshots from the YouTube video on insulin demonstration and how to check your blood sugar by Atrium Health Floyd. Floyd nurse Jolie Puckett demonstrates how to properly self-administer insulin. The great thing about these videos is that through the Decreasing Diabetes program, the nurse or the educator could come by and show the patient how to check their blood sugar and how to administer insulin. The nurse will leave the room and the patient is still within the hospital. They can actually pull this video up on YouTube and it will show them how to do it, and they can watch it as many times as they want. It's very detailed and very user-friendly. It is in English and in Spanish to better serve our community. How am I, as DNP, going to measure success of this program? I would like to do a post-hospitalization survey. After patients are discharged from the hospital, they are sent surveys. This program will target the patients that have been provided education, and they will be sent a post-hospital survey, ideally 2 to 3 weeks after discharge. This would allow the patient to have some time at home and to utilize the new education. Following up with a primary health care provider will be able to ask questions about their care there with the MD or the NP. The primary care provider can ask about medication compliance. An A1C can be drawn in 3 months to see if glucose levels are trending down. If a patient is readmitted to the hospital, a trigger will alert the team and the patient can be seen again by the Decreasing Diabetes Program team members. The goal is to decrease readmissions related to diabetes complications. A large part of our program will be patient satisfaction. I would like to do a survey before they leave the hospital, in person. The survey will be at the discharge process, and I would be asking specifically about the Decreasing Diabetes Program. We want to know how comfortable the patient is with self-managing all aspects of their diabetes. I would also want to send a survey out after discharge about how their education went, how are they feeling, are they using the phone apps. Phone applications are easy to use, providing over 1,000 apps on health and diabetes management to help the patient track the progress. Are they feeling better overall? Are they enjoying more of their diet options? And how is their mood and weight? In conclusion, the Decreasing Diabetes Project would be a great addition to the hospital setting for diabetic patients in Northwest Georgia. The goal is to decrease diabetic complications and increase the knowledge and compliance within the patients. This is a secondary health provision. It is Decreasing Diabetes as the main program name. I discussed my DNP competencies, all the teammates, the education that will be needed, how would we collect data, and what will be needed to do the follow-up surveys. This is my references. I have to have 2 pages just so we can be able to read them in APA format, alphabetical, and this is page 1. And this is page 2 of my references, still in APA format. Thank you for taking the time to listen to my project.